This PowerPoint presentation is on knee injury prevention. I'm Lloyd Ireland. I'm an orthopedic surgeon. I've been dealing with this since the mid-'80s, and I must say I'm not putting myself out of business at this point, so this is something that we can really, as healthcare providers, reduce the risk of injury, but also improve performance. We owe this to our athletes to work in this area of preventing knee injuries from happening, specifically ACL tears. The different sections of this presentation are introduction, mechanisms of injury, core, definition of what the core is and some studies that we've done, risk factors, prevention programs, and conclusions. In the mid-'80s, I was involved in USA basketball, and Cindy Wall, athletic trainer, and I observed that there were a lot more knee injuries in the elite female basketball athletes compared to the males. So in the 1988 Olympic trials in Colorado Springs, which was before Dream Team for men were involved, all amateurs, we did a study looking at the injury rates, which was a retrospective study. We did a questionnaire given to all of the elite basketball athletes that were asked to come try out for the 1988 Olympics for basketball. There were 80 males, 64 females. We looked at the number of knee injuries. This is what they came in with. 13% of the males had knee injuries, 53% of the females had knee injuries, and 20 of the group had undergone surgery. 6 were male, 20 were females who had had several surgeries. And ACL reconstructions far outnumbered in females compared to males, 8-2. So this was an observation, and from this I asked some questions that I saw clinically and tried to take it back to the lab to figure out why this was occurring. When we look at the number of injuries in high school athletes in the United States, Title IX, there were 4 million injuries according to the CDC from 71 to 72. When we go fast forward to 2005-06, there were 7.2 million injuries at the high school level, significantly increased incidence of injuries, and these are overall injuries. When we look at the rates of these injuries, 2.4 injuries per 1,000 athletic exposures, and in this CDC study there were no statistically significant differences in sex in soccer compared to basketball. So in this high school study, the injuries of all injuries were not statistically significant in gender in soccer and basketball. If we break this down further, sport-specific injury rates in practice and competition, high school surveillance study, we see that the greatest incidence of injury is in boys football, as we would expect. But look at the difference in the rates in competition versus practice. So a significantly greater rate of injury in boys football, 12 compared to 2.5 in practice. Wrestling is also up there, but in all of these categories, the game or competition is greater than practice, which makes us try to determine where we need to have the most coverage with athletic trainers or physicians, and this is certainly in a game situation. When we look down at girls soccer, a little bit less injury rate, overall injuries than boys soccer, but girls basketball has a greater injury rate, specifically 3.6 in competition compared to almost 3 in boys basketball, and then the rate again is slightly about the same in girls basketball and boys basketball. It's important to look at injury rates by athletic exposures, and this is per 1,000 athletic exposures, not just in numbers. So when we look at the comparison of these two, competition to practice, almost a 5-fold greater incidence of injuries in boys football, 2 in wrestling, 1.6 in soccer, 4.7 in girls soccer, 2.6 in girls basketball, and 2 in boys basketball. Women's participation skyrocketed pre-Title IX, 1972, 300,000, 2008, 3 million participating in high school, so we have a 10-fold increase in participation by girls. Get to college, pre-Title IX we had 30,000, and now in 2008, obviously 5 years ago, we now have 205,000, so a 7-fold increase in participation of girls, women in college athletics. The NCAA had an injury surveillance system that started in 1989 and went through 2004. When we looked at basketball rates of injury, again per 1,000 exposures, there were some variations each year, but the average for women was a significantly greater rate of ACL injuries. As you look here on the right, the ratio average was 3.38 greater ACL injuries in women compared to males. So over the years there have been some variations, but overall there's still a significantly greater rate of injury in women compared to men for basketball, almost 3.4 times greater rate. When we look at soccer, not as great a difference, but continuing, even though some intervention programs and some different training, different coaching has come along over the last 20 years, still a greater rate of injuries to the ACL for women compared to men, 2.75 greater rate of ACL injuries. Now we'll talk about mechanisms. Look at this mechanism. She brings her knee up to her chest. That's the heart attack of the knee. A lot of these injuries in basketball occur in the paint. You can see how she's out of her cone of stability, so to speak. Comes down in an awkward way. Her trunk is forward. Her hip ends up being an internal rotation and adduction, and she falls forward, trying to catch a ball before it goes out of bounds. She's being guarded, so she is in a perturbated situation where she's not landing on 2 feet, as in volleyball, coming down more in control. She's out of control, being guarded by this person. Perhaps the pass was overthrown, and she's going to grab it, try to keep from going out of bounds. So definitely a situation where she wasn't just landing as we teach people in some sports of jump straight as an arrow and land light as a feather. She didn't have that opportunity in this situation under the goal in the paint. Takes 70 milliseconds to tear an ACL. Something that you can use is Varum, Valgus, rotation, out of control movement. Out of her cone of stability. So if her feet were underneath her, she would have less chance of tearing the ACL, but this is not possible when she's trying to stop and grab the ball and keep from going out of bounds. So think of Varum as a mechanism of injury. Valgus, knee is in valgus. In my opinion, this comes from a trunk and hip position when she's landing. Her foot does get stopped quickly in the paint, in the shoe floor to surface interface is an abrupt stop. If we played basketball in sock feet, we might not have as many ACL injuries, but we would not be able to rebound the ball and come to an abrupt stop. We'd fall down more often, but maybe not tear as many ACLs. But if we look up proximal, trunk is forward, opposite side, hip goes into internal rotation and abduction, and then something's got to give, and unfortunately it's the ACL that pops as they get into this functional pivot shift. So the observation of ACL injury patterns allows us to develop hypotheses in the lab for computer modeling, bring the lab studies back out to the training room, figure out what's going on in the lab with more sophisticated gait analysis, force plates, and then bring our results to the training room so that we can observe and put athletes through training for prevention. And also if they do tear their ACL, we need to get them back on the field or court as safely as possible by doing these programs. Joint position and muscle activation is critical to knee stability. It's not the absolute strength of the muscle. It's a combination of the order of firing, how fast the muscle can fire, and also the joint position. A safer position of landing is with the hip and knee more flexed, giving the hamstrings and trunk musculature and hip abductors a little bit better chance of uprighting the ship. So strength is not as important as timing of activation. Hamstring firing on a flexed hip and knee are more efficient, and the worst is a quadricep dominant position in an extended hip and knee. So I observed these positions. A position of no return where we see ACL injuries occur is shown on the right in this position of safety. This was published in the Journal of Athletic Training. So when we look at this, the safe position shown on the left, think about the muscle activity and the body alignment. So the back is in a normal lordotic position. The hips are flexed. There's little rotation. The knee is flexed. The landing pattern is on both feet, controlled with balance. In the position of no return, where ACL injuries occur, the trunk is forward, rotated to the opposite side. The hip is in adduction and internal rotation. Therefore, the knee is forced into a valgus position, oftentimes with less flexion when initial landing, and at least in basketball, the tibia is externally rotated and the foot is pronated. There is more stress on the anterior cruciate ligament bundles in internal rotation than external rotation, but still these injuries are more common with the tibia in external rotation. So this is the reference, the Journal of Athletic Training in 1999. We looked at injury mechanisms and tried to do some line drawings. Hopefully we can do better analysis in the future, even with computer analysis, and look critically at joint positions. The real question in this scheme is, when is the ACL torn? Most likely it's torn at the frame third from the left, because on the last frame on the right, when the knee is in that ugly position, the ACL has already been torn. So this is an athlete who has torn her anterior cruciate ligament at an elite college level. You can think about an ACL tear. These are the two bundles of the ACL, the anteromedial bundle and posterolateral bundle. Ligament and mucosum and the fat are right in front of our face. So this is like a blowout. It's like a sudden blowout. This is showing the Lockman test at the time of arthroscopy. So basically the ACL tears apart like the end of a rope or cooked spaghetti strings. It just blows apart, and the patient does feel a pop or feels a shift. And typically that's where the tibia shifts forward, doing a functional standing pivot shift maneuver. Most ACL injuries are all or nothing. We do see a few less than 5% partial ACL injuries. Posterolateral bundle is providing more stability for a reduction of a pivot shift, anteromedial reducing the anterior drawer. So a mop-in tear, like a blowout. The cone of stability, I think, is a good concept. As your foot is underneath your pelvis, you can land in a more flexed knee position and with less rotation. When we're out of that core cone of stability, then the knee will tend to buckle and the femur will rotate on a fixed tibia and an ACL injury will occur. So think about trying to keep your feet under your hips when you're coaching patients on the best landing positions. And the one on the right is the unstable position causing ACL tendon injuries. The cone of stability on the left, if you can keep that, then you're less likely to have a ACL injury or patellar dislocation. We see bone bruise patterns consistent with this anterior dislocation of the knee, if you will. So the bone bruise pattern of being on the back of the tibia, the posterior aspect of the tibial plateau, and the mid-third of the femur indicate what happens when they tear their ACL. Their knee is in a subluxed position or a dislocated position. And then when you think about it, they self-reduce this when they go back on their back and bring their knee up into a hyperflexed position. This makes their knee go back into place. On occasion, we see a patellar dislocation with an ACL injury, but this is not very common. We don't see many MCL injuries with an acute non-contact ACL injuries, indicating that there is certainly more rotation involved in this injury, and the tibia has an anterior dislocation as opposed to a valgus, true straight valgus position in the frontal plane. It's rare that we see an articular cartilage injury in the lateral femoral condyle that we need to do a microfracture fix, but this is something that we always look at the time of arthroscopy. But the bone bruise pattern is in the subchondral bone, and typically we do not see a lateral femoral condyle fracture very often. Another mechanism, this person wasn't thinking as she took the ball out of bounds, so she wasn't ready for that activity, so she just rocks back in a similar kind of mechanism. She puts all of her weight on her right side. See how her trunk is forward, her hip is adducted, and then her knee gets driven into valgus, her foot stays put, and she tears her ACL. So sometimes it happens when our guard is down or after the play, as it did in this Division I basketball athlete. So the position of no return, is it really knee valgus? Seen from the frontal plane it is, but we don't see many MCL injuries or lateral patellar dislocations. So when we look at it from the sagittal plane and also based on our bone bruise pattern, the injury is really a landing pivot shift. So the tibia anteriorly subluxes, the hip internally rotates and adducts. So the femur appears to first go into internal then external rotation, and this valgus collapse is actually anterior tibial translation in my observations. These are normal individuals being asked to do a mini squat, the male obviously on the left and the female on the right. If you look at the different positions, and this probably starts up at the pelvis with rotation, but the male on the left is able to keep his hip over his knee over his foot. The female on the right, again, no knee problems when she's standing in a single leg stance. See, she drops her other pelvis, opposite side of her pelvis, I should say. Her knee is in valgus, but that is driven by the hip being in adduction and internal rotation. So she's basically trying to stay upright when she's doing a single leg mini squat. And then the foot is externally rotated, pronated, and the tibia is in external rotation. So she's trying to maintain her posture and maintain upright, and she does that through a variation from the male seen on the left. Already a position of no return potentially. If you add the speed of stopping and changing direction from a jump, this gets very accentuated. And again, 70 milliseconds to tear the anterior cruciate ligament. When we look at the position from the side, the sagittal view, this position of no return, the pelvis is anteriorly rotated. There's excessive lordosis of the hip. And then the femur internally rotated, adducted, and the knee tends to go into valgus and some hyperextension. That position of safety is more flexing the back like a mad cat in neutral, hips over knees over ankles, with the pelvis in neutral, not anteriorly rotated. Again, these positions have been observed, and then we take it back to the lab to do more testing to determine what trunk control, strength, and how that relates to lower extremity landing mechanics. And then these are these individuals from the side. You can see doing the mini squat, the male on the left has his back more straight. Female on the right has a very anteriorly rotated pelvis and hyperlordosis when she is seen doing that same mini squat as we showed from the front. There are muscle-dependent individuals just as far as their structure, and they're ligament-dependent individuals. This swimmer on the right does go into hyperextension, and she is more dependent upon her ligaments and capsule of her knee. The football player on the left is a muscle-dominant individual, and he would be more likely to have a muscle injury like a hamstring strain than tear his anterior cruciate ligament. Looking at plank, the normal male in the bottom, and this is a normal female but has a different strategy. So the middle picture, she wasn't instructed on how to keep her back in less lordosis and rotate her pelvis differently. So that's her normal. So just something as simple as putting a broomstick behind their back. When we asked him to do a plank in the bottom, this is his position, and the female was up on top. When she was coached to keep your back straight, rotate your pelvis as on the top, she did much better. But the natural position, because of the lordosis and the anterior pelvic rotation, was in the middle for her. But she is coachable, and things can be changed with hip trunk positioning, strengthening. Core stability is defined as lumbopelvic hip complex, where a person's center of gravity is located and all movement begins. This provides a stable base for optimal kinetic chain function, and a weak core does not allow for production of efficient movements. And if we don't have efficient movements, this will lead us to possible injury, including other injuries such as ankle sprains, stress fractures. So our core is very important for prevention of lower extremity injuries as well as upper extremity injuries with shoulders. We'll see problems with rotator cuff and throwers because of a weak opposite hip. So think about the hip even in evaluation of your upper extremity injuries. Spine stability system, as described by Punjabi. Clinical instability is loss of spine's ability to maintain its pattern of displacement under physiologic loads. So there's no initial or additional neurologic deficit, no major deformity, no incapacitating pain. Definition of spine stability. Punjabi's work is very interesting and informative to read, and helps us understand the core. I would recommend that you look up the core in this article in Current Sports Medicine Reports. The spine stability system is neuromuscular control, neural elements, passive subsystem, osseous or ligamentous elements, and an active subsystem, which is the muscular elements. Core stability improves efficacy and musculoskeletal conditions, reduces low back pain and lower extremity injuries, again from this same article. In a recent textbook by Noyes and Barbara Weston, we were asked to do a review on single leg squat and gender differences in core strength and lower extremity function during a single leg squat. We can easily do a single leg squat in the office, have them stand up on a step stool, or just do it barefoot on the floor. Ask them to do a mini squat on either leg. Typically, if they're not too confident, they will do it on their non-injured leg, or the one that hurts they won't put down first. Do it on the opposite side, indicating that they do have pain and some tentative thought about that they're going to hurt their knee if they do that. In our article, we talk about the reasons for this knee valgus, faulty kinematics with ipsilateral trunk lean or contralateral pelvic drop, hip adduction internal rotation, as we've shown on the mini squat maneuvers in previous pictures. There's also altered neuromuscular activity, less activation of abdominal musculature, more gluteal activation, and strength deficits leading to knee valgus. These strength deficits are in the lateral trunk flexors, hip extensors, abductors, and hip external rotators. So these strengths about the hip and the trunk we need to work on, but we also need to work on proprioception, ability for the brain to know where the trunk is in space, and these faulty kinematics and altered neuromuscular activity. In many think tanks over the last 25 years, we've looked at the factors, which can be modifiable or not modifiable. And fortunately, the consensus has always been that the factors involved in ACL injuries, non-contact in the female, are modifiable. They fall into a neuromuscular biomechanical group. The ones that we can't really change, we don't feel are as important in prevention of ACL injuries, and these are the not modifiable: anatomic, structural, and hormonal. So these are not as important factors as the modifiable ones. So we should emphasize the modifiable factors for return to play as well as prevention programs. And we are doing this by trying to keep people out of that position of no return. The single leg squat gives clinicians information on neuromuscular control. We're also doing more studies on plank. Plank measures lumbar and pelvic control in the side or sagittal plane. You can see excessive lumbar lordosis when you have people do the plank test, and you can show them what the right way to do plank is and do studies for improvement of trunk control as well as strength. And you should observe these individuals in the fatigue and non-fatigue states. Our injuries in basketball oftentimes occur in March Madness. They're playing harder, but maybe they're in a little bit more fatigued, or maybe they don't have as much brain-to-body awareness where they haven't re-jump started their computer and done frank trunk training and not just playing. Core stability exercise principles, we've talked about this. Spine stability system. Instability is loss of spine's ability to maintain its patterns of displacement under physiologic loads. So there is no initial or additional neurologic deficit, no deformity, no incapacitating pain. That's the way we strengthen the core. I've been involved with some great basic scientists, biomechanics. Irene Davis-McClay was involved in a lot of the research that I was done. She is a PhD. Biomechanics, was at the University of Delaware and now is in Boston. These are 3 of the studies that we have done where, again, observation of core weakness led us to go back and test the core and see what the relationship of the core was to the lower extremities. This is where these articles were published. When we looked at hip strength in females with and without patellofemoral pain, we usually concentrate on the quadriceps, but in this study, we looked at hip abduction and external rotation. In symptomatic females, those with anterior knee pain had weakness in the hip abductors as well as external rotators compared to age-matched controls. So the question in a chicken or egg thing is which comes first, the hip weakness or the knee pain? Our suspicion is that the knee pain comes first. But to improve their symptoms, you can't just work on the quadriceps. You got to get the hip stronger first, because with every step, they're having abnormal mechanics of gait. We also looked at core measures of stability in college athletes and followed them for injury. We had 80 females, 60 males. They were in two sports, basketball and track. We measured core stability prior to the season, and we kept injury records. This study was done over a couple of years. This is our method of measurement of strength. This is a handheld dynamometer, which is shown in the middle. So we did hip strength with them seated, internal and external rotation. On the left, these are the measurements of core, sit-ups, extensions, and in the bottom, the plank with a handheld dynamometer. Then we did hip abduction in the middle on the bottom, and then quad, hamstring, shown on the right. And then we normalized this for the lever arm and body weight. There was also a fatigue test per Shirley Sarman, the side bridge test, time in seconds the athlete was able to maintain a side bridge. The athletes did get bored with this because some of them could maintain it for quite some time. The side lowering test, which is a good one, described by Dr. Sarman, physical therapist from WashU in St. Louis. Straight leg lowering, 9 degrees per second. When the back raises up off the table, off the tester's hand, that's when you get the degree and record it. So our results from this study were that hip external rotation strength was the only useful predictor of the injury status. We only had one ACL injury in these 140 athletes, but that female athlete had significant weakness in her hip abductors and external rotators. Males compared to females, males produced greater hip abduction, external rotation, and lumbar spine stability measures. Uninjured athletes were significantly stronger in their hip abduction and external rotation. So when you set up a study like this, you really need to do all lower extremity injuries, patellar problems, ankle sprains, stress fractures, and you need a very large group of individuals to get enough power to make any predictions or give us any meaningful information about ACL injuries. Another study that we did, the projection of tibiofemoral valgus doing single leg stance and a single leg squat. This is something that can be done in the training room. The stool behind her is adjusted to her height to make that 45 degrees where we have her bend as far until her buttocks touches the stool. So we look at the average projection angle that's taken with a picture and then just a overlay of what the angle is. So she's in 3 degrees of valgus in straight single leg stance. When she squats, she goes to 8 degrees of valgus. And we take an average projection angle, and we looked at how that related to hip strength. Our conclusions from this study were that simple clinical measures allowed testing of athletes in the training room sitting. There was an increase in tibiofemoral valgus that was explained moderately, not statistically significant, by core strength. We need more numbers and more studies like this, again, to take something from the lab and make it relevant in the training room so that we can utilize this on more athletes. We have ongoing research at the University of Kentucky with Brian Noreen, who's a PhD that actually trained under Dr. McClay Davis. We're doing gait analysis, some three-dimensional analysis of the lower extremity, post-ACL reconstruction, some individuals that haven't been hurt, comparing gender and sports. So the risk factors contributing to ACL injuries intrinsically are things that can't be changed. Alignment, hyperextension, physiologic rotatory laxity that we see in females that is normal and symmetrical. The size of the ACL, this really isn't gender dependent. It may be more genetic of how big is your ACL. The notch size and shape reflect the size of the ACL. A smaller ACL in diameter creates a more narrow notch. Hormonal influences, although there have been some studies that are based historically, we still have no evidence that ACL tears occur because of or during a certain cycle phase, and studies cannot really be done historically. They must be done by measurements of estrogen, progesterone, either by saliva, urine, or blood. The real question with hormonal influences is we don't see more back sprains or ankle sprains or stress fractures during certain part of the menstrual cycle, so why should we see increase in ACL injuries? And then there certainly is the inherited skills coordination. Some athletes never get hurt. You can tell that they're moving like a Michael Jordan, or others that have very smooth movement patterns. Took Jerry Rice several decades of playing professional football before he tore his ACL. Walter Payton, ability to move his feet. So some of this is inherited skills and coordination where they're just some very superior athletes to others of us. There are also extrinsic factors which can certainly be changed, and then we see combined factors, some of which are changeable, some are not changeable, so intrinsic and extrinsic. The ones that we can really change are strength, conditioning, shoes, motivation. The potentially changeable are these combinations that we can also change, I think, and this is what some of our prevention programs are aimed toward. Proprioception, meaning position, sense, and balance. Neuromuscular, order of firing of muscles, and acquired skills. Bruce Benyon, the University of Vermont, looked at risk factors for lower extremity, reviewing the literature. This was published in the British Sports Medicine Journal. And of the factors he looked at, 14 intrinsic and 5 extrinsic. The ones in yellow are the ones that are a increased risk of significant risk of ACL injuries, and these include being female, previous injury or inadequate rehabilitation, which we see in ankle sprains as well. The main problem with an ankle sprain is you re-sprain your ankle, so previous history and inadequate rehabilitation. Narrow notch, which would indicate that there is a smaller ligament. When I ask biomechanics folks whether or not a small ligament is more apt to tear, they can't really tell me the answer to that, but a smaller ligament would, by common sense, be more likely to tear. The extrinsic factors, definitely that are changeable, are the games, their increased level of competition. When they're going full out, there are greater incidence of injury in games. And also, this is in soccer using edge cleats, and we can certainly change the shoe type. So the risk factors, non-contact ACL injuries in females, being female, not related to the hormonal levels or the cycle, previous injury, inadequate rehab, narrow notch, meaning smaller ACL size, game, first degree relative, younger age in females, landing patterns in valgus, extended knee, core dysfunction, and weakness. So these are the things that we can change. The majority of these, particularly the last couple with prevention plan and improvement of speed, landing patterns, enhancement of performance through exercise and strengthening. Risk factors for lower extremity injuries: fatigue, previous injury, shoe surface interface, game situation, awkward landing, and a combination of these. So these are what we want to try to change. When we look at family history as a risk factor, this was a study by Kirkley and Fowler and others, the familial predisposition toward tearing the ACL, case-controlled study. There were 472 subjects. First-degree relatives, participants with an ACL tear, were twice as likely to have a first-degree relative with an ACL tear. So if you have a first-degree relative that tears their ACL, 2 times more likely are you to tear your ACL. What about moving up in play? In this study from Scandinavia, Soderman concluded that soccer athletes who were less than 16 and moved up were much more likely to be injured than the seniors. So don't move your young athletes up. Youth injuries are increasing, and we don't need to escalate the youth to be mature athletes, so keep them in their age group. In our experience at Kentucky Sports Medicine, female athletes were younger than males by 5 years. This is the group that underwent ACL reconstruction and were basketball athletes. So females' average age was 15 and males was 20 in our group that underwent ACL reconstructions. Hewitt and Meyer have done some great analysis of landing patterns, popularizing several concepts of dynamic valgus of the knee as a reason for these increased knee injuries in females. So in this, the mechanistic connection between trunk, hip, knee, and ACL injuries is a very good way to think of these injuries occurring from the standpoint of with a spurt in growth, without a spurt in growth. And I would suggest you look back at this because it really puts a lot of the things together that we've been talking about with the mechanisms of injury. If we think about the mechanical model linking these, there is lateral trunk motion in relation to ground reaction force vector. There is a hip adductor torque, and then greater knee load occurs during cutting and landing with ACL. So this group has talked about torques and movements about the knee that cause females to have increased risk of injury. So there are some that are high loaders and some that are low loaders at the knee. And this is this conceptual model relating lateral trunk motion to increase ground reaction force vector and hip adductor torque and knee load. These biomechanical studies have led them to develop the PKAM, which is the probability of high knee abduction moment as it relates to high risk for ACL injuries. Their conclusions based on numerous studies are that this high PKAM or knee abduction moment leads to increased ACL risk. Summary of these 4 articles looking at PKAM and risk were that this algorithm helped to predict the probability of high PKAM based on 2-dimensional video data. It was these 15 to 16-year-old female soccer basketball athletes, and the PKAM ranges, average values ranged 0 to 1 with 84% sensitivity, 64% specificity. And their conclusions were that a knee abduction moment predicted ACL injury status. These females were pre-screened, and if we do that, they would demonstrate neuromuscular control, increased valgus, joint landing, which would predict ACL injuries. They looked at 205 female athletes in soccer, basketball, and volleyball. They did 3D joint angles in this study and joint loads during jumping loading, and they had 9 athletes tore their ACL, 2.5 times greater knee abduction moment, and 20% higher ground reaction forces. So the PKAM in their studies predicted ACL injuries. When we go to Gutchess and Vermont study, which was published in 2012 in the American Journal of Sports Medicine, they took this algorithm and tried to see if this was really true. They did a prospective cohort with a nested match case control analysis. So it was a 2-dimensional study. They looked at this high knee abduction moment with standard video cameras to provide measurement tool for larger population. They wanted to test to see if the PKAM did significantly predict ACL injury or not. Their hypothesis was that the clinical algorithm would predict athletes at risk for increased ACL injuries. In this study, they had 1,885 female athletes. They were recruited over a 3-year period. There were numerous sports as listed. They had 20 ACL tears and 45 controls who underwent the full study and the video analysis. These are some of their diagrams looking at the initial contact position of the knees. You can see there is valgus when they did this drop vertical jump. And then this is the lateral view, initial contact with the ground reaction force during the landing phase, and then the maximum flexion was recorded during the drop vertical jump. Their results showed no relationship between risk of suffering ACL injury and PKAM as determined by the clinical-based algorithm. Conditional logistic regression analyses did not reveal statistically significant relationships, so they concluded that the PKAM was not associated with non-contact ACL injuries in our group of injured athletes and matched controls. So we do need to question studies that are done, and just because it's written does not mean it's gospel. Additional research is needed to develop alternative clinical-based algorithms for prediction of ACL risk. This should be able to be applied in an efficient manner to large groups of participants involved in ACL injuries that are associated with high risk of ACL injuries. So by my interpretation, if we don't know the factors causing increased risk of injuries, we can't predict why prevention programs are working. We really need to continue to look at the risk factors and determine what the real risk factors are before we can make sure what we're changing and if it is truly working. The programs do seem to be working based on follow-up when we look at groups that aren't being intervened with and groups that are. So publications should stimulate us to go back to the lab and ask the most basic question and see if we can prove the most basic question. or disprove it. Which now leads us to the title of this PowerPoint, Prevention Programs. As we talked about, we really still need to look at the risk factors and determine and prioritize what the risk factors really are. We know how the mechanisms occur, so a lot of the prevention programs are to keep you out of that position of no return, make sure you're in as good a shape as possible, not fatigued, and do landings in a safe position. So E. Letha Hunter Griffin is the editor of this Prevention of Non-Contact Injuries that was published by the Academy of Orthopedic Surgeons in 2001. I was involved in this publication in some of the think tanks, and this is a nice paperback format to give us some of the concepts of what we should be teaching our youth to prevent ACL injuries. Injury prevention should really be as simple as ABCs: agility, balance, core, strength. ABCs. We should be able to keep it more simple and more basic. Get a lot of complaints and questions from female athletes and their families about, well, they can't get in the weight room. You don't really need to get in the weight room for these programs. You need to have a field or a court somewhere that you can do these programs. You need to have some tape, some cones, some bands, some balls. Simple as ABCs. What the programs have in common: they emphasize safe landing positions, neuromuscular recruitment, should be sport specific, make it fun for the athlete in that sport, and the program must be done properly and participation documented. This is where, when some coaches only do these programs, we don't really have supervision that the physical therapists, the athletic trainers, the physicians can give to do the programs properly. And if the athletes aren't doing it, we aren't sure if they're really participating in the programs. And then the other side is we need to look at the injury rates. So we need to look at all lower extremity injury rates, not just ACL tears. Prevention programs that are out there, these are the .coms to get to these. Published results, they do reduce risk of injury. We just need to continue to look at the risk factors to prioritize or have a formula of risk factors for individuals to better counsel individuals of, if you play this sport, you're at this risk for injury, factoring in certain things like movement patterns, objective measurements of movement patterns, genetics, other sports, risk of the sport themselves the athletes are participating in, multiple sports. Sometimes if you don't get ready for that sport and have a periodization program, a strength program, then you're at more risk for injury. So the adolescent females, as published here, Tim Hewitt's work, as we talked about, he's been a pioneer in testing, developing these programs and taking it to the lab, documenting things with gait analysis, force plate analysis with landing patterns. Soccer, Bert Mandelbaum and his group have .com ACL Prevent. This is more related to soccer, but again, a statistically significant risk reduction in a group that has done these prevention exercises. And Team Handball, Greta Mikkelbust in Norway has done a lot of great work with team handball. Again, a lot of things where they can pass to each other, kind of be off balance and in a perturbated position, but one under control, where they hopefully don't tear their ACL. We don't see injuries occurring in training rooms or in rehabilitation facilities. It's usually back on the court when these occur. These are the prevention program websites, the PEP program, ACL prevention program, soccer, Santa Monica. This is Tim Hewitt, Leveling the Playing Field, How Neuromuscular Training Gets Girls Back in the Game. looking at his coaching of how to land, and observing in the lab with the markers, giving feedback, motion analysis to the athletes.
Very good. Straight up and down. Good. Good. Noticing how she's stopping to make sure she's landing this one correctly. Good. Boom, boom. Very nice. Very nice. And stop. Again. Nice. There, better. Hold it. There you go. Forward. And stop again. And begin. Soft. Very nice. Look at that. Wonderful. Knee over top of feet. No wobbling there. Good. Much better. You're doing this. Other than that, I was going to say you're doing very nice.
Those are very hard exercises to do. For those of us who haven't done them, do some of these again on the mat, landing, good hip over knee over ankle position. That was an athletic trainer who was instrumental in doing one of the original Hewitt gathering information of the athletes. This was published in the late 80s of this program that did reduce the risk of ACL injuries by doing this prevention program. Perhaps it's better, instead of saying prevention, to talk about prehab and improvement of performance, because if you have an ACL that occurs after you tell them it's not going to occur, then that can be a problem. So talk about running faster, jumping higher, and improving their performance by these core hip strengthening programs, and not reduction of injury as you sell it to the athletes, coaches, and parents. The PEP program, prevent injury and enhance performance. So I think that concept is one that is a very good name for these. So the enhancement of performance is what we should be selling. So this study was published in 2005. He does have some updated information as well. 20-minute program performed throughout the season, 2 or 3 times a week, not on game days. Soccer athletes age 14 to 18. And look at the similarities in these programs. So the one on the right is not the way to do it. The other one is sticking landings in a more bent hip and bent knee position. So you can see how she's more on the left in a good position in her back, high kneeing, and much less valgus in that individual on the left compared to the right. The results: there was an 88% reduction of ACL tear rate in the first study in 2000 and a 74% in the follow-up study in 2001. This is a rate per player in trained versus untrained. See there in the trained in the upper column, relative risk was less, and the p-value was 0.001. Prevention programs are working. Question still remains why. We have a lower extremity prehab or prevention program that incorporates some of the same activities that you saw. Again, make it be possible on the field or the court. I'd like to thank the James E. Ireland Foundation and Post Time Productions for putting this together, but who really put it together were the athletic trainers at the high school and clinic level, as mentioned there. This is available online. Please utilize this in your clinics and with your coaches to implement programs such as this. This is what the program is, lower extremity injury prehab. So we have 12 different exercises: high knees, butt kick, side lunge, side-to-side cutting, high knee shuffle, power skip, lunge, forward backward cutting, high knee hold, toy soldiers, hopscotch, high knee figure of 8, karaoke, vertical jump. In these, we look at their form, their ability to do this. A lot of rotation involved, landing, looking at the position of safety in landing. And this is the YouTube link. Robin West at the University of Pittsburgh has developed an ACL prevention app for the Android and the iPhone. This is what the app is. So it's only $1.99. Ours is free on YouTube, but it's not on your phone. So again, look at areas in your community, however you can get these exercises to the field and to your athletes, utilize them. ACL prevention, mental preparation, physical training, coaches' cries of landing softly, land light as a feather, like a spring, jump like a spring, land light as a feather, more bent knee position. Get down, the more bent knee hip position is a safer position of landing. Return to play after ACL reconstruction, typically, in my experience, it's about 6 months. If we look at gait analysis, gait may never return to normal when we look at three-dimensional analysis, force plate analysis, or it takes at least a year. The question is how to measure by objective how to measure how far along we are functional assessments by objective measures. Jumping, landing, treadmill, functional assessment and PT, fatigue, confidence in landing, and it really takes athletes a while to get their confidence back of the way that they're landing. So confidence usually adds another 2 months to get their confidence back. They may be running and cutting, but to really get their confidence back and be ready to go back in the game, which is the way they got hurt, usually takes 2 months more to get their confidence back once they start playing. This is one of our functional assessments from 10 years ago. So she flunks. She really can't land this very well. Her hip is in adduction valgus. So if she went out on a basketball court, we would be very concerned that she was going to tear her ACL. She doesn't have any ACL problems, but you can see how out of control she is. You can see how she's trying to remain upright, but look at her trunk, look at her hip, and then look at her knee going into such significant amount of valgus. So her hips are in internal rotation. She can't land on the tape, which is what she's being told to do. So she is a high-risk ACL train wreck getting ready to happen. If you look at this individual who has had an ACL done, he tends to drag one foot. So that one on our left, his right leg, is the one that he had an ACL done. So he kind of drags it, and it's a little bit more extended. So this is where activities post-op, like the Eric Heiden board, doing some of this activity to get them working their hip and their knee better. So that's his right knee that had an ACL reconstruction performed. So he's not yet ready to return. And the athletes get that. If you have them do that in therapy, then they kind of understand there's a difference. This individual, again, a high risk, no knee injuries, but she would if she went out there. So you can see where she's kind of in a less flexed position. Not sure what she's doing with her hands, but I guess that's one strategy. And then this individual, again, she's all over the place, normal knees, but she just doesn't really get the cries of rotational control and how to do it. And this is naturally how she does it. She really hasn't undergone any training. She's going to get hurt. Other things are these stop. Do they have to run through? Can they stick a landing? So if she can't stop and kind of keeps running through, that's a deduction. We can do other things like hopping, other Y balance tests, other tests have been created. You do want to do a strength test. The absolute strength is probably not as important as the firing, but we should do a closed chain strength test. Athletes who have done ACL reconstruction, bone, patellar tendon, bone will tend to develop patellar tendonitis if their quads aren't strong. So good position in doing this hack squat machine and do strength tests before we let them return to play. Extension machines can cause anterior knee pain, so usually I'll use something that comes up through the ball of the foot as opposed to the force on the anterior tibia. just some items in our functional assessment that we need to incorporate, and work with your physical therapists, athletic trainers to figure out what the functional assessment outcomes are best for you. Return them to play safely. Measure them in the training room or the rehab facility. Remember the core. A lot of different muscles in the core. It's the combination of the position of the trunk and hip and how efficient the muscles are, how quickly they form the order of firing, of how they fire to protect us from injury. So don't forget the core. Landing is everything. No gravity, we'd be really out of ACL. As ACL surgeons, we'd be out of business. So gravity, it works against us for injury prevention, but allows us to play sports and play basketball and soccer. Not all injuries are preventable. Things do happen. We need to focus too on determining the rank and order of importance of risk factors. Injury prevention strategies. It's harder to sell than performance enhancement to coaches. Sell performance enhancement, so then when somebody does have an injury, you are not wronged, or you didn't give them the wrong information that I'm going to prevent every ACL injury. So sell it on performance enhancement. Key to understanding ACL prevention, understanding the rank and importance of the risk factors, and again, the extrinsic ones, the ones that we can change, are more important, and we can implement change. You never see it coming. This is on the Serengeti. Little Tommy Gazelle running across, lions asleep. So injuries, things do happen. Male lion sitting there, females are out hunting. Tommy Gazelle pizza delivery. So things do happen. ACL injuries do happen. So sell this as performance enhancement, making you run faster, jump higher, and with a hope of reducing risk of lower extremity injury. The bottom line with long-term results of ACL reconstruction is, can we prevent arthritis? Can we restore normal knee function? Evidence-based, really it's unknown. Experience-based, it is known, and I do believe that we can reduce the rate of osteoarthritis. We need more long-term studies. We can restore a stable knee, but not a normal knee. This is a 36-year-old professional basketball athlete who had been playing basketball for several decades, probably 3 decades. I had been seeing her for patellofemoral osteoarthritis of the knee shown on the right. Her injured knee was the one on the left, so you can see in the bottom right where her patellofemoral joint had narrowing, a little lateral tilt of the patella. She had osteophytes in her notch, so she had osteoarthritis of her involved on the knee on the right, which I'd seen her for. She was playing professional basketball and tore her other ACL, so we marked that as injured. Underwent allograft ACL reconstruction, not by me. These are her x-rays 2-year post-op. So you go from a knee that looked pretty normal to a very arthritic knee. And the question really is, did she have some years of mileage on her knee from doing all that impact for 30 years? So you do a reconstruction of her, she's stable, and she develops osteoarthritis in her medial and lateral compartments with an allograft ACL reconstruction. This is 3.5 years, increasing pain. She did have some mechanical symptoms of some loose bodies, and she begged me to scope her, which I did. This is what her arthritic knee looks like. This is what her graft looked like. In the upper right is her normal, or her ACL reconstruction. That looks great. Good position, taut. But she had some type of underlying injury to the knee that was probably more of a repetitive years of doing impact basketball, and basically had an arthritic knee. She got a little better from her degenerative meniscus tear debridement, but not a lot. See, the articular surface is totally worn out, grade 4 changes. So the real question with these cumulative years on knees. Should we think about this as pack years of smoking on lungs, pack years of activity on knees? And if you do an ACL reconstruction and somebody's been playing basketball for 30 years, you better make sure you tell them that there could be an underlying arthritic component to this that we can't see on our x-rays, perhaps doing MRs in these, looking at bone edema, other imaging to see what the activity of the bone is to give us more information about how much arthritis is involved, because certainly stiffness trumps instability, and her instability is not an issue, her arthritis is an issue. So maybe there are too many pack years of basketball. If you play over a certain period of time, maybe you should be counseled on stopping playing. Registries, we need more registries. There's National Cruciate Ligament Registry in Norway. These are the websites to look at. Get the information in when they get injured, not trying to follow them after. With National Healthcare Plan, this may be easier for us to do. Kurt Spindler and his great group of multiple centers have developed many different planets. There is the Moon group, there's the original Moon group, and now we have the Moon Shoulder group. We have the Mars group, which is a revision ACL group, Meteor group, which is related to meniscal tears and osteoarthritis. This is the resource that you can use to learn about this, Vanderbilt Sports Medicine. And this is what we really do need to answer some of the questions about osteoarthritis and who does better, what graft choice is better, by getting patients enrolled in these studies and centers finding them and have a good yield rate of who we can find. Very encouraged that Dr. Spindler and others are working on this. The uneven playing field. This was an article in the New York Times, May 2008. Janelle Pearson, high school soccer athlete, multiple injuries to both knees. And I think it's interesting to look at her mindset. After surgeries, she would rehab hard, get back on the field, compete fiercely. And this one is very eye-opening to me, hope not to be re-injured. When I do an ACL reconstruction, we do rehab, I want that athlete to go back with the confidence they are not going to get injured, as opposed to this spin of hope not to be injured. If she hopes not to be injured, I guarantee you she'll be injured. So our concept, like we talked about with confidence, is you have to have the confidence in the training room, the rehab facility, before you get on the field. And you know you're not going to be re-injured. It should be the confidence level, as opposed to fear that you are going to be re-injured. Establish risk factors, prioritize order of risk, document what factors have changed, the blind man and the elephant. Can't really tell what they're looking at until they put it all together. It's an elephant. Look at the risk factors. Document what factors are changed by intervention programs. And we've got to choose the correct risk factors and implement the programs at multiple centers. If you pick the wrong risk factor or poor study design, you may be out of a ride to work. Oh, shoot. I hope this was helpful. Use these ideas to implement programs with your own active athletes. Keep communicating, asking questions. If you observe something, take it back to the lab and get the question answered. Thanks for listening and watching.